Hello everybody. My name is Dr. Nikhil Nayakawade. I am working as an associate professor at the Devapati College of Pharmacy, Kolhapur. My area of specialization is pharmacology. So today I will talk mostly about general principles of chemotherapy. So what is chemotherapy? So chemotherapy is nothing but use of chemicals, either naturally deriving or derived from chemical or from microorganism with selective toxicity against bacteria, viruses, fungi, protozoa, helminths is called as a chemotherapy. So what is meant by selective toxicity? The aim of the chemotherapy is to kill the pathogen or cancer cells without damaging the host cells. So let's move on to see the definition of antibiotics and antimicrobials. So what are antibiotics? These are the substances produced by an microorganism which selectively suppress the growth or kills other microbes at very low concentration. What are antimicrobials? So they are nothing but any substances of natural, synthetic or semi-synthetic origin which at a lower concentration kill or inhibit the growth of microorganism with little or no host damage. So let's see the history of chemotherapy. So at first, before Paul Ehrlich's period, that is Paul Ehrlich he is the founder of chemotherapy, or one can call him as a father of chemotherapy. So before Paul Ehrlich, several attempts have been made in the history, such as Chinese people were using curd for treating the boils, or in Indian or Hindu people, they were using the chaul mogra oil for treating the different bacterial infection. So what Paul Ehrlich has studied and what his thought were when inventing the different chemotherapy drugs. So what he found out that different dyes were actually active against the bacteria. So what he saw, if the dye can stain the bacteria, so why not use these dyes to treat the bacterial infection in animals and humans. So first he used the trypan blue in animals and he found a success. Then later he used the arsenic based compound and dyes to treat the syphilis. After him, the penicillin was discovered by Alexander Fleming, followed by him the discovery of sulfonamides by Gerard Domac, who used the first, or who invented the first sulfur drugs, Prontosil. Followed by him, natural antibiotics of penicillin was purified by the Florian chain, and then the development of streptomycin was discovered in 1940s by Selman Waxman. After Selman Waxman, both these groups, Paul Ehrlich, Gerard Dogmack, Alexander Fleming, Florian Chain and Selman Waxman, they all were received the Nobel Prize in Physiology or Medicine. After 1950s, newer antibiotics were discovered, followed by different anti-neoplastic drugs. In early 2000s, targeted therapies and monoclonal antibodies were also discovered to treat the cancer. So let's move and see what are the principles of antimicrobial therapy. So to treat the bacterial infection, one could first identify what type of bacteria is present in the patient. So it can be done either with the different laboratory tests such as staining, culture and PCR. Then once you identified the causative agent or bacteria, then you can target your therapy with the targeted therapy. So you can use the narrow spectrum antibiotic over the broad spectrum antibiotic, because broad spectrum antibiotics are also effective in the known bacteria, but it can also cause resistance and adverse event in the long term use in the patient. So can you use the antibiotic therapy for the chronic infection? That is in the real question here, because for the acute infection, one can use the antibiotics for 5 to 10 days therapy, but for the chronic infections such as bronchitis and COPDs, the long-term use of antibiotic can cause resistance, so they are not preferred for the chronic infections. So next one is the host factor. So what are the points in the host factor? So age, pregnancy, comorbidity, allergies and immunostatus. So age of the patient is also important to determine the dose and frequency of the drug. Next one is the pregnancy. In the pregnancy, there are several antibiotics which are contraindicated. For example, tetracycline is not given to the pregnant woman because it can cause the teratogenic effect in the fetus. So next one is the comorbidity and immune status. So if the patient has some immune disorder or if he's immunocompromised or if he's undergone immunosuppressive therapy after organ transplantation. So such category of patient are usually treated with bactericidal antibiotics in place of bacteriostatic because of their immune status. Next one, selection of drug. So selection of drug is mostly done based on the type of bacteria. So type of bacteria can decide whether you can use the narrow spectrum antibiotic or broad spectrum antibiotic. Next one, you can choose either bactericidal or bacteriostatic antibiotic based on different factors such as type of bacteria, age of the patient, and host factors. In pharmacokinetic factors, the effect of antibiotics is mainly depending on the minimum inhibitory concentration of antibiotic in the circulation as well as the site of infection. So if the antibiotic is not orally well absorbed, so one can opt for using IV or parenteral route, and you can achieve the minimum inhibitory concentration of the specific antibiotic in the patient. So patient-related factors includes allergy and renal diseases. So if any patient has allergy, for example, penicillin have the greater risk of hypersensitivity reaction. So if the patient is allergic to penicillin, if you know that, so you can either opt for other antibiotics other than penicillin. In case of renal disease, if patient has a renal disease, known renal disease, then you can avoid giving the tetracycline and aminoglycosides because they both have the adverse effect on nephrotoxicity. So cost and availability is also important because the antibiotic should be cheaper and readily available. Resistance pattern in the community hospital should be studied well, because if you know that certain antibiotics is resistant or certain bacteria are resistant to few antibiotics in the hospital acquired infection, so you should avoid using that antibiotic and opt for another antibiotic. So let's move the dose and duration of therapy. Inadequate dose may cause resistance, so the appropriate dose or adequate dose should be given, and this adequate dose should maintain the minimum inhibitory concentration in the blood and the site of infection. Generally, for the short course antibiotic therapy, 5 to 10 days is required for the acute infections, whereas for the chronic infections such as tuberculosis and leprosy, it requires a long-term therapy with mostly more than one drug. So combination of antibiotics are given to avoid the resistance in the long run. So next one is the combined use of therapy. So to achieve the synergism, decrease in minimum inhibitory concentration of one antimicrobial agent in the presence of another. So the classic example here is the use of sulfonamides and trimethoprim. If you give the sulfonamide and trimethoprim in a separate manner or and not in the combination, so these two drugs are generally bacteriostatic, but if you give them in a combination, so they work as a bactericidal because they disturb the folic acid metabolism in the bacteria. So to prevent the emergence of resistance, mutation conferring resistance does not cross over from one antimicrobial agent to another antimicrobial agent in the same class. So generally, for this reason, most chronic infections like tuberculosis, the combination of antimicrobial agents are preferred. So next one is the test for cure. Once you given the antimicrobial therapy, if the symptoms may disappear, but the pathogen is still there in the body, so different tests are to be performed to check the susceptibility of the antimicrobial agent is still there, or the presence of bacteria in the site of infection or in the circulatory system is there with the different laboratory tests. So let's move to the prophylactic chemotherapy. So more common, actually prophylactic chemotherapy is more common in antiviral drug, because in antiviral chemotherapy, once you identified the virus in the patient, at that time the growth and multiplication of virus is already going on, and in that case if you start the antiviral drug, the effect is minimum. So for immunocompromised patient or patient which has the comorbidity such as bronchitis and COPD, if these patients are going to travel abroad, or if they travel to the different environmental condition, such patients are given the 1 week or 2 weeks antiviral dose prior to their travel to avoid the surgical site infection. So generally prophylactic antibiotics are given to have the lesser complication at the end of their recovery period. For the dental extraction and urinary tract infection, COPD and chronic bronchitis, such procedures or such diseases, the prophylactic antibiotics are given. Immunocompromised patients such as HIV and AIDS, and patients who are taking immunosuppressant, those who have undergone the transplantation, these patients are usually given the prophylactic antibiotic to have the major complications or superinfection due to their immunocompromised ability. So let's move to the classification of different antibiotics based on their mechanism of action. So the basic difference between the bacterial cell and human cell are: the bacterial cell have the cell wall, whereas human cells do not have cell wall, they have the cell membrane. So first are the inhibition of the cell wall synthesis. These includes the beta-lactam antibiotics such as penicillin. So the bacterial cell wall is made up of 40 to 50 layers of proteoglycans. So the beta-lactam antibiotics such as penicillin binds to penicillin binding protein in the cell walls, and they alter the synthesis of cell wall, thereby destruction of cell wall, and all the organelles and cytoplasmic material from the cell wall is damaged due to the osmotic effect, and the bacterial cell dies. Likewise, inhibition of protein synthesis occurs, or inhibition antibiotics which works on inhibition of protein synthesis, they generally binds to 30S and 50S ribosomes in the bacterial cell, and they disturb the translation phase in the bacterial genome, thereby production of faulty proteins in the bacterial cell, thereby break or killing of bacterial cell. So next ones are the antibiotics work with the inhibition of metabolism. So generally sulfonamides, sulfa drugs and ethambutaols, they work on the metabolism of folic acid synthesis in the bacteria, thereby reduction of, or because folic acid is one of the vital component for the bacterial cells to survive and proliferate in the body. So if there is if they inhibit or stop the folic acid synthesis, the bacterial cell will not survive and the bacteria will die. Next one. So the classification also made based on the spectrum of activity of antibiotics. For example, narrow spectrum antibiotics such as penicillin G, streptomycin, erythromycin. These antibiotics are either work on the gram-positive bacteria or gram-negative bacteria. For example, penicillin G is only effective against gram-positive bacteria because the gram-negative bacteria has a cell wall comprising of one layer of lipoprotein and one layer of proteoglycans. So the penicillin is unable to find the penicillin binding protein in the gram-negative bacteria. So if the penicillin cannot penetrate the bacterial cell wall, the effect of or sensitivity of penicillin is negligible on the gram-negative bacteria. The broad spectrum antibiotics, they work mostly on both the gram-positive and gram-negative bacteria. So what are the problems with antimicrobial therapy? So first is the toxicity, then hypersensitivity reaction, drug resistance, superinfection, and drug tolerance. So we will go through one by one here. So in toxicity, there are two types of toxicity. One is local irritancy and systemic toxicity. In local irritancy is nothing but the irritation and formation of pain and abscess at the site of infection. In the systemic toxicity, almost all antimicrobials produce a dose-related organ damage. For example, tetracycline and aminoglycosides, they have the nephrotoxic, and tetracyclines mostly damage the livers in the host. In hypersensitivity reaction, all antimicrobials can cause some form of hypersensitivity reaction in the host. So these reactions are generally unpredictable and unrelated to the dose of antimicrobial agents. These can range from normal rashes on the skin to as severe as anaphylactic shock in the patient. This example includes the penicillin-induced anaphylactic shock, which is more severe form of anaphylactic shock, and patient may die if it is not identified. Next one is the drug resistance. Microorganisms are insensitive to the antimicrobial agents are called the drug resistance. So drug resistance are of two types. One is natural resistance and acquired resistance. In natural resistance, microbes show resistance to a certain antimicrobial agents naturally. For example, gram-negative bacillia or gram-negative bacteria is insensitive to penicillin G because they cannot have, the penicillin G cannot penetrate the cell wall of bacteria. In acquired resistance, this is a resistance developed by an organism which was sensitive before due to the use of antimicrobial agents. These includes the mutations in the bacteria as well as gene transfer in the bacteria. So what are super infections? These are the new infection occur in a patient having a pre-existing infection. These type of infections are difficult to treat. The classical example of this infection, if a patient is admitted for the respiratory problems in the hospital and if he is ventilated, so if he receives or if he gets the opportunistic infections in the hospital setting, so first he will have some kind of viral infection or viral pneumonia, and then he will have another infection from the hospital settings, that is super infection. These infections are more common in the immunocompromised individuals such as patient with AIDS, diabetes, systemic lupus erythematosus, and prolonged steroid therapy, people who are taking steroids on a regular basis. So they will suffer for super infections. Thank you.